Hello, everybody, and thank you for joining our webinar today. This is The Road to Success, an ophthalmologist guide to MIPS. My name is Randy Marsden, VP of Value-Based Care at Anatomy IT, and I'm also joined here today with Renee Fryer, who will be assisting me, and she is our Director of Value-Based Care. Our agenda today, we're going to go over the most important things you need to know about the MIPS program for this year. We'll start with an overview of the quality payment program and go through each category. As we are approaching the end of the year and the last quarter of reporting, it's really important to make sure you've got everything checked off and ready to go, ready to submit. We'll also be going over the rulemaking process and commenting on how you can help make an impact on the program as it changes year to year. We'll also go over how we are helping our practices succeed at the MIPS program. If you're new to Anatomy IT, I just wanted to say welcome. We are a managed service provider that also is providing new services in value-based care, particularly around the MIPS program, as well as ASC quality reporting, HIPAA, 21st Century Cures Act compliance, and other health IT related initiatives to help make sure you're reporting and getting the best score possible, which leads to the best reimbursement. If you're not familiar with the program, first of all, let's talk about Quality Payment Program, or QPP. This is a Medicare program that was enacted as a result of the macro law back in 2015 to end the sustainable growth rate formula. There's two ways to participate. The merit-based incentive payment system, or MIPS, which is for traditional fee-for-service providers, which a majority of specialists, and especially in ophthalmology, are going to be part of this. The other option is the advanced alternative payment models, which there's various different models available that either are one or two-sided risk models, and based on your patient population and the patients that you see through the APM, you may be eligible for a lump sum bonus. Otherwise, you're participating in a similar program as the MIPS program, and we support clients in both of those options. We're going to focus our discussions today on the MIPS program, which will be similar if you're in an APM that's not advanced. It's the same requirements, since a majority of ophthalmologists are still in traditional fee-for-service. So first of all, let's discuss the impact. So your MIPS score is anywhere from 0 to 100 points, and 75 points is the threshold to avoid any positive or negative adjustments. So if you got exactly 75 points, your payment adjustment would be neutral and your fee schedule would remain unchanged. If you go below 75 points, you'll gradually receive a negative payment adjustment up until negative 9%, which is the maximum. And then on the flip side, if you go over 75 points, you're going to get a positive payment adjustment that's scalar up to 100 points. So depending on how the penalized providers perform, that's the pool of money used to reward the positive payment adjustment for the top providers. So that's why we don't know the exact amount, and that will vary each year. Besides the payment adjustment, which I know is the top priority for everybody, I also want to mention that there is a public reporting aspect to this. Medicare has a Care Compare site, which is designed for patients to find clinicians in their area. If you were to go look up your own practice, I'd recommend doing that. You can see how you're scoring, how you compare to other clinicians, other practices. And it does show a lot of the MIPS data in there, including your performance on quality measures expressed as a star rating. So it's really important to make sure you're picking measures that are specific to the services you provide and not picking just general measures just to get those in there, because it may look like you're performing poorly on those when you could have picked measures more relevant to your care, like cataract surgery or retinal detachment or glaucoma management. Now, in order to participate in MIPS, or I guess to say the reason you need to participate in MIPS is you're billing more than 90,000 in Part B covered professional services, and you see more than 200 unique Part B patients, and you provide more than 200 covered professional services to those Part B patients. This time period that they're looking at is based on the latest complete CMS fiscal year, which is October 1st of 2021 to September 30th of 2022. This eligibility determination will update again at the end of this month and show any changes from the original eligibility, which is usually released by the end of the year. So we'll get another refresh of October 1st, 2022 to September 30th of 2023. So if you go in and look at your eligibility and you're wondering why maybe a clinician's not been picked up yet, or that a clinician's still associated to your practice that already left, or what's very common is we have practices that think that they're a small practice because they have less than 15 clinicians today, but during the eligibility period, they did have enough clinicians to be in a large practice. So you really want to use the eligibility that Medicare is assigning you. And the initial eligibility is what we have access to right now. The final eligibility will be available toward the end of the year, and Renee's putting in a link to where you can go check that. When you go to that website, you just put in your NPI numbers to see your eligibility. However, we recommend, if you haven't already, to set up an account with QPP and link your account to your practice. That way you can see all of the clinicians that are part of your group or that CMS is expecting to be reported for your group. So if you do have to participate in MIPS, you'll be scored on these 4 categories, including improvement activities at 15% of your score, promoting interoperability at 25%, cost and quality are both at 30% equally. On top of the total 100 points available here, there's also a complex patient bonus that can add up to 10 points to your overall MIPS score. This is calculated from claims based on your patient's risk, based on diagnoses that are submitted. Now, these weights that you see here may be adjusted depending on certain circumstances in your practice. For example, if you file a hardship for one of these categories, or let's say you're in a small practice and you choose not to report promoting interoperability due to the burden of that additional reporting, then you don't lose that category completely. It's just those points get moved to other categories. Now move over to quality reporting, and I have Renee, our Director of Value-Based Care, here to help you.
Thanks, Randy. All right, we'll get started going over quality. Okay, so some quality basics. So for the quality categories, Randy said it's 30% of the score, but depending on if you have any other category weights, it could be more, depending on if you're a small practice or a large practice as well. That will play an impact. So for the quality category, it is a full year of reporting. You earn up to 60 points within the category, and that is multiplied by whatever the weight of the quality category is. And you're going to submit at least 6 measures, one being an outcome or a high priority. We always recommend submitting no less than 10, if even 15 or more, depending on your practice size and subspecialty as well, to be able to report on as many measures as possible to maximize and get your highest 6 scoring. And then also, as noted, quality is weighted at 30% of the MIPS score for traditional reporting if you're reporting on all 4 categories. And then over on the right side for bonus points. So you receive 6 bonus points for being a small practice. That is considered when you have 15 or fewer clinicians that bill under their own NPI and recognized within QPP. You could actually have less than 15 clinicians, but if some clinicians who've left already are still tied to your TIN, and the QPP details come from PACO. So if that information hasn't been updated correctly, you could actually not be considered a small practice, even if you truly are. So it's important that credentialing and the billing team is always making sure they're updating PACOs appropriately, because those 6 bonus points make a difference. And then the other bonus points is you can earn up to 6 points for category improvement from the year prior, similar to what Randy touched on right before. There's 3 different ways that you can report for this category: claims reporting, and this is available only for small practices. So this is when you have a code that is included in your Medicare claims, and if it's relevant to a particular measure, they're continuing to make claims reporting significantly harder. The scoring is harder, and they continue to either drop or suppress measures. So we definitely recommend either manual reporting if you're still on paper, which is still considerably hard to score well, or if you're within an EHR, or if you're willing to transition from paper to an EHR, to be able to report through the EHR or the registry. So many EHRs have their own built-in registry. And then the reason there's a registry that's separate is, for example, American Academy of Ophthalmology has the IRIS registry. So those have CQM and ECQM measures that are available, which are available through QPP, but then also you have QCDR measures, or quality clinical data registry, and those measures were created by that particular company. So AAO created the QCDR measures, and those are only available within that particular registry. All right, so some quality scoring changes. So data completeness. So what data completeness is for each quality measure that you report on, there has to be at least, for 2023, there has to be at least 70% of the data that's captured within that particular registry. So an easy example would be you have 10 clinicians, 9 are in the EHR, 1 is still on paper, maybe doesn't want to transition off of paper, but the other 9 are capturing all their data within the EHR. Because by assumption, if you just submit all your data, CMS assumes that 100% of your data for each quality measure is included. So if not every patient is included, hence that 1 clinician that's on paper, you need to submit what's called data completeness to attest how much of the data that you submitted through the registry was actually charted and captured within the EHR. So it would be for those 9 of the 10 clinicians had the data. Our company is able to do that calculation on behalf of practices. We have a program where we're able to load in the claims data. We can either help a practice with that, or we request the details. And then we're able to get that data loaded to determine the exact patient population for each quality measure. And for example, we would list out, say there's 15 measures. One measure, there might be 94% of the data, another might be 98.75%, another might be 76, et cetera, and so on. So as long as it's at least 70% of the data that's being captured. Another common scenario, especially as a result of several EHRs being sunset in 2023, say, for example, you switch to a new EHR in March, and the first 2 months, just a clean break of 3/1/2023, and the first 2 months were in that EHR that's been sunset and no longer is in existence. We could just submit your data from March to the end of the year, and assuming that you would reach that 70% threshold. The other thing to factor in with this 70% is depending on the denominator cutoff. So some measures, if they're surgery-based, the cutoff might actually be September 30th. Some might be through November 30th, depending on if they're looking at a 30, 60, or 90-day window. So that is something to factor in as far as your patient population with each measure. With all that said, if this sounds really confusing, this is something that we're able to help our practices with. And if we're not working with you, we can definitely help you with this as well. In 2024 and 2025, it's going to be going up to 75%. And then beyond 2025, it's expected to continue to increase further and further to just increase that threshold. Of course, encouraging practices to be reporting through an EHR ideally, as well as to have the majority of the clinicians through that method. And then there were some not changes, they were just maintained. So if there's a quality measure in the first year within the MIPS program, they maintained in 2023 to give a 7-point floor. So what that just means is by reporting on that particular measure, if it's the very first time that it's in the MIPS program, by default, you start out with 7 points, which is fantastic, especially since many other measures are 0 to 7 or 0 to 10. So it's great to have a measure when it's in the first year as an incentive to report on that. And then if the quality measure is in the second year of MIPS, then that floor is 5 points. Those particular measures, because they're so new, they're not benchmarked. So there's no historical data to reference to be able to give a score other than those 7 or 5 points respectively. However, if enough practices report on that particular measure and there's enough patients within each of those practices that report, they could receive what we refer to as the live benchmark, which would go by that particular year's data. And so that measure, say that 7-point measure, you actually have a perfect score. Let's pretend like it's perfect. And that measure gets a benchmark. then after all the data is calculated, your score could go from 7 to 10 points, just because it's perfect. So that's an easy one to assume that it would switch to a perfect score, which is 10 points. So even when the data is submitted, it still could continue to go up. All right, so some info and tips on quality reporting on the left-hand side. A few measures have expanded documentation requirements. So the first one is measure 226. This is the tobacco screening and cessation. This is the one for adults, so it's patients 18 and up. And I'm pointing that out because there is also an adolescent one that's patients age 12 to 20. So for the adult one, the new change for this year is it also includes nicotine products. And then the other inclusion measure is measure 130, the med documentation and attestation. That one also includes cannabis products. One thing to note about cannabis is because it's not federally legal in all 50 states, it's not currently available within the pharmacy directories like SureScripts, for example. So if you tried to search for cannabis, it's not available. We were told that once it is federally legal, then they would formally add it. So for now, this would be something that you would have to free type in your system. If your system is only able to pull in data from a specific pharmacy company like SureScripts. Otherwise, if you're able to just add it as a formal med, then you could go ahead and do that. But if not, you would just want to free type that. And then for ophthalmology in particular, the IRIS registry is managed by Verana Health for all practices starting in 2023. We do have a great partnership with Verana, and we can assist with the transition. And for those of you who have gone through the transition, there's a lot that's involved with updating mapping details, even keyword searches that the previous company, FigMD, already had those details. You have to go through that process all over again. So that's something that we're helping to either assist practices with that we've been working with to just submit on their behalf, or if it's new practices we're working with, we know the types of questions to ask to drill down for particular measures, so that way we can get your scores up as early as possible instead of waiting, months and months, because we know exactly what they're looking for. And some of you have already been using the Verana Health Registry. Last year, they implemented for practices that were in ICP or IMD, if they also had the PM system of using NextTech with ICP, or if IMD's PM system. So it was more of a clean transition. So some practices have been using the registry. Every other scenario and all other practices are now using Verana starting in 2023, though. And we meet with them at a minimum, we meet with them twice a month. And depending on the complexity of some practices, certain account managers that we have will actually meet with them multiple additional times throughout the month, outside of our 2 formal meetings we already have. All right, so a couple of finalized measure changes. The first one is for measure 117, diabetes eye exam. I had touched on before about claims-based reporting being much harder. So claims reporting, this measure was removed for claims reporting in 2023. There was a clarification for MIPS CQM. So for example, those who use the EMA registry, if you just use the EMA MIPS registry, they use the CQM version of this measure. They adjusted the age of the date of the encounter to be used to determine patient eligibility for the measure, as opposed to like the age of the patient from the start of the performance year. So slight distinction, but enough, something that we had actually caught historically. And then for the ECQM, so if you report through Verana Health, for example, that I just touched on, you would report using the ECQM version of that measure, and the patient age is determined as of the end of the year. So sometimes there's different distinctions between the different reporting types for the measures, and there's different scoring parameters. Traditionally, a CQM is more of an attestation-based measure, so it's typically a lot more strict in the scoring, whereas an ECQM measure is going to map to that clinical data. So there's a lot more studies and research that can get pulled from ECQM measures, so there's a lot more leniency. So we really like that Verana Health is able to capitalize on as many ECQM measures as possible. And then the second measure is measure 191, cataract surgery, 20/40 visual acuity. There was a denominator exclusion that was added, tractional retina detachment. And then an ECQM denominator exclusion also added heteronymous bilateral field defects. The other bullet point towards the bottom that's pretty small is indicating measures that received a benchmark in 2023. So I touched on before about a non-benchmark measure, that 7 and 5 point floor, where if it receives a live benchmark, then you could score anywhere up to 10 points. So there were multiple measures that received a historical benchmark. They've been in the MIPS program long enough, and there was historical data to reference to give that particular measure an actual score at the time of submission instead of hoping that they would receive a live benchmark. So there were several measures that were included. Few of them are IRIS 51, IRIS 44, IRIS 2, and measures 385, 226, and 238. I know that's a mouthful, but it was enough measure changes that it was noteworthy. We wanted to include this in here. All right, so these 4 measures were previously not in FigMD. So if anybody used the Verona Health Registry in 2022, you may have already seen these measures. But if you use FigMD in 2022, then these 4 measures are new. 137 melanoma recall. So this is looking for tracking of future skin exams and having that patient in a formal recall to make sure they don't slip through the cracks. Not as relevant and not as common for ophthalmology, but still absolutely possible. And we typically see this with oculoplastics more, where they would be tracking or reporting on this measure. The next one is another melanoma one, coordination of care. So this measure is capped at 7 points. So say you have a perfect score, you can't score 10 points. You would score 7 points. And this is looking for within a 30-day window. So we have that underlined because this one is very strict. They're looking to see if you sent the path report with the clinical findings and showing, for example, margins are clear, or maybe if margins weren't clear, if patients coming back for a re-excision or follow-up treatment, to give that, to provide that update to either the referring provider or the patient's PCP. They're also, the patient is also eligible for an exclusion if, say, they don't want you to send the letter, or maybe they don't even have a PCP and they weren't referred. So instead of that counting against you, you're able to get excluded. And then the next one, 402, the tobacco use. I mentioned this earlier about the adult one. So this is the adolescent one that was added to Verona Health. This one is also capped at 7 points. And then a difference between this one and the adult one is for the adult one, they're only looking, you only get credit for patients who are identified as a tobacco user. For this one, you get credit for that scenario that I just described. And by documenting also if the patient is not a smoker or a tobacco user or a former one. So you'll also get numerator credit for both of those scenarios. And it is age 12 to 20. So it's a unique one where there's unfortunately an age overlap between the 2 measures. So as long as you're consistently charting, then potentially for patients 18, 19, and 20, they would show up in both measures, and then you would get numerator credit for both for that particular age group. And then the last one is measure 419, overuse of imaging for evaluation of primary headache. So if a patient has a formal headache diagnosis, if they were ordered a CT or MRI for that patient, then they'll automatically show up in the numerator, which this is the first bullet point is that it's an inverse measure. So a 0% score is a perfect score. They do this for measures where their intention is to not do something. So instead of them just wording it differently to make it a little easier, so everything 100% was perfect, for some measures that are inverse measures, a 0% is perfect. So if they have a headache and a CT or MRI was not ordered, then the patient would be technically, quote unquote, unfavorable. But in this case, that's a good thing. So basically, any way you look at an inverse measure, think of the opposite. So a low score is great for this type of measure, and favorable means unfavorable. So the opposite is always what you want to look for this particular measure. And the majority of registries should indicate somewhere if it is an inverse measure, or they'll have an icon somewhere to let you know. But that's also something, if you work with us, we have a list of all the inverse measures, and we've definitely clarified that for several of our practices who get concerned about a score of like 1%. And it's no, that's really like you have a 99%. So we can also help with that clarification. All right, I'm going to hand you back over to Randy to go over the promoting interoperability category.
So this is basically your use of your electronic health records. This is continuing to be a 90-day reporting minimum, so you don't have to report for the entire year. In fact, we recommend starting the year off with promoting interoperability to focus on that while you're waiting on quality data. But if you have not got started yet, then your last days to get started are coming on up. You'll need to do 90 consecutive days throughout the entire calendar year if it cannot bleed over into next year. So get started on that if you haven't already. There is a new update required, the 2015 edition Cures update, which is an update that your EHR would provide. There may be other software that you're using on top of that, like a separate patient portal, for example, that also needs to be updated. So make sure you're checking on the certified health products list or Chapel on the ONC site to make sure that you're on the correct version, and work with your EHR and other software developers to make sure you have that latest update. You need all of the features that are included in that update during your entire period of reporting, which is might be why you're still waiting to start. But you don't need the certified version until the last day of the reporting period. So just keep that in mind as you prepare for the last quarter of this year. The measure requirements to avoid zero in promoting interoperability contain attestation statements, measures that need at least one patient in the numerator or one action in the numerator, or to use an exclusion if it's applicable to your practice. There's a total of 100 points available in this category, along with 5 bonus points. And this is weighted at 25% of your MIPS score in traditional MIPS, 30% if you're reporting at an APM entity level, or 0 if you're in a small practice and you do not submit promoting interoperability data. These are the attestation statements for promoting interoperability. So the first is, like I mentioned before, that you used 2015 CERT Cures update during the reporting period, the prevention of information blocking, the ONC direct review, which are just both statements related to the Cures Act and to audits that may be conducted by ONC as part of your submission. There is also the annual security risk analysis, which is part of HIPAA. This needs to be updated annually under the MIPS requirements. And if this is something that you haven't been able to accomplish yet, or that you need assistance with, Anatomy IT does offer this service. And it's similar to the annual security risk analysis, there's now also the annual Safe or High Priority Guide self-assessment, which is similar to HIPAA, but dives deeper into a lot of the issues that we're all facing today, including ransomware and cyber attacks. Besides the attestation measures, these are all of the points-based measures that make up the entire category. You need to report on every measure, at least having one in the numerator for each one, or attesting to an appropriate exclusion. A lot of the changes here really come down to points being readjusted based on a new measure being now required. Patient electronic access, which is giving patients access to the portal, as well as the API ability to use assistant software of their choice, has been reduced from 40 points down to 25. There is now 10 points in querying a prescription drug monitoring program for Schedule 2 opioid or Schedule 3 or 4 drugs. That is at 10 points now. There is an exclusion, or there's several exclusions available for this now. If you're unable to legally ERX those drugs, or you have less than 100 relevant prescriptions, or for 2023 only, this causes a significant workflow or cost burden. For ophthalmologists, if you're not prescribing more than 100 Schedule 2 opioids or Schedule 3 or 4 drugs, then you can consider using that exclusion. However, if you do query the prescription drug monitoring program, this might be some good points to get if your other scores in the other areas aren't doing as well. The next objective, health information exchange, has alternative objectives you can use instead of these measures here, including bidirectional exchange or participating in TEFCA. Otherwise, the measures listed here are what you'll be using and you may continue to use. Sending health information and receiving and reconciling health information have the same requirements and same exclusions as last year, but the points are now reduced to 15 points each. The main reason we're seeing points reduced, besides adding that query PDMP measure, is that the points for the public health and clinical data exchange objective have increased to 25 points. And this is in response to the COVID-19 pandemic and the need to get these electronic reporting methods set up to help increase the amount of data that we have on issues like COVID-19. The first requirement is to report both the immunization registry and the electronic case reporting requirements. The options here are either registering for these, testing, or being in full production with sending data to your public health agencies. There are exclusions available. For example, if it's not relevant to the care you provide, which for ophthalmologists, the immunization registry, unless you're doing immunizations, would be not relevant, and that's an applicable exclusion. Electronic case reporting will depend on what your public agency is obtaining at this point from your specialty. A lot of state public health agencies are just focusing on hospitals and urgent care, or primary care for now. So you should reach out to your local agency, which may be at the state or county or city level, depending on where you're at. And you can check their website for their readiness of reporting in these programs. This is something that our advisors check for our clients to confirm each year. And if they are not required because the agency isn't ready, we usually pull a letter or request written confirmation from the agency in the event of an audit. In addition to reporting those, there's 5 bonus points available for reporting to one of the following: clinical data registry, public health registry, or syndromic surveillance registry. There's not 5 points for each. It's just if you do at least one of these, you'll get the extra 5 points added to your overall score. The most common one our clients use is the clinical data registry, which IRIS registry is considered one. There are other EHRs, for example, Modernizing Medicine has their own built-in registries that are available at NextGen as well. So you could check with your EHR if you're not using IRIS, as you may have a registry you're reporting on that can get you that extra credit. Now moving on to improvement activities. So this is a 90-day reporting period minimum. You can earn up to 40 points in this category. You'll need enough measures to hit 40 points, which depends on your practice's special status and factors, which are available in your eligibility on ppp.cms.gov. So typically, high priority activities are worth 20 points and medium are worth 10 points. So you would need at least 2 high priority, 1 high priority, and 2 medium priority, or 4 medium priority activities to get the full score in this category. If you are in a small practice, a rural area or health professional shortage area, all of this is doubled. So you would only need 1 higher priority or 2 medium priority activities to complete this category. And then this is weighted at 15% of your MIPS score, or 20% if reporting to an APM entity. Here are the top finalized changes for improvement activities for 2023. Not too many major changes here, but if you are reporting any activities related to quality clinical data registry or QCDR, which, for example, if you're using activities related to IRIS registry, you're going to want to make sure that those activities are still available and still relevant. There were modifications to several of these, and they also removed improvement activities that were duplicative to these other QCDR measures as well. So if you're using that use of QCDR feedback reports that incorporate population health, you'll want to look at the other measure or other activities that are related that information may have been consolidated into. Also, there's 4 new improvement activities, and these ones we find are relevant and common to work with in an ophthalmology practice if you need a replacement. Otherwise, if your improvement activities have not been removed or changed, you can continue to use the same activity unless it specifically states in the data validation requirements that it can only be used once. And rounding out our categories with cost. So this one, I think we can all agree, has been the biggest struggle to handle as we're starting to interpret our 2022 cost reports. This is a full year of reporting. The total number of points in this category depend on how many cost measures you get picked up in. This is all scored in real time, so we're not able to track the cost score reliably until the period ends and we look at your beneficiary level data to see what happened for the year. It's weighted at 30% of your MIPS score, that were reweighted to quality if there are no measures that apply. There are bonus points available, which is a up to 1% improvement score on top of the category score for measure score improvement from the year prior. And this is all coming from Medicare administrative claims, so there's not anything you're specifically submitting to CMS for this. Now, there were no changes to any of the episode-based cost measures, but I did want to highlight the ophthalmology measures that Medicare considers to be relevant. We may disagree here, but first of all, there's obviously the routine cataract removal with intraocular lens implantation. This is looking at all of the services that are relevant to cataract surgery up to 60 days prior to surgery itself, and then up to 90 days after the surgery. All of that data is combined and calculated into a single episode, and then it's grouped by bilateral versus unilateral procedures. And keep in mind, if you do each eye within 30 days of each other, that will be considered a bilateral procedure. After 30 days, it's split up into 2 unilateral procedure subgroups. It's also split by ASC or hospital-based, and that's all done to help normalize the cost across each of those different subgroups. There's at least 10 cases minimum in order to get picked up in this. So if you're just occasionally doing cataract surgery, you shouldn't have to worry about this. That 10 episode case minimum is based on if you're individually reporting or group reporting. And then the data that you're able to see in the QPP site is based on the prior year. It will show you the actual score along with beneficiary level data, which shows you which patients were picked up in the measures and which services were included. Just a note, at the time of this recording, the reports that are being produced are inaccurate. They are duplicating bilateral cases across the board. So if you see a lot of duplicates in there, that is why it's very difficult to try to interpret these right now. We've been working on cleaning up that data for our clients to be able to make sense of it. And CMS is aware of this issue, but it did not change your score. The score was based on nothing being duplicated. So just keep that in mind as you review that information. The next one is the diabetes chronic condition cost measure, which we didn't expect anybody to get picked up in this. Through our commenting efforts in past years, we were able to communicate to Medicare that they should not be including ophthalmologists in this measure just because they're seeing diabetic patients, because ophthalmologists don't have full control over that care. This measure is designed for primary care or endocrinologists who manage the diabetes, but as a result of a flaw in the measure where they are attributing diabetes cost measures to groups and not individuals, if you reported as a group last year, you may have been picked up in this measure. Obviously, there is a way of getting around this cost measure, which CMS admits to, which is just reporting clinicians individually. We have been working with various different specialty societies and with Medicare directly in hopes that they can reverse this and correct it retroactively, and also make this change so that clinicians don't get unexpectedly picked up in this if they report as a group. And we hope to know more once the targeted review process ends. Upcoming. If you haven't already reported any issues that you have with that cost measure, I definitely would suggest sending in feedback. You might get a standard response back, but I think the more they hear that this is an issue, the more likely they are to respond. You may also get picked up in the melanoma resection cost measure, depending on your caseload there. And if you have any PAs or NPs working in your group and you're reporting as a group, you may also get picked up in the total per capita cost measure, which does actually exclude ophthalmologists from the measure, as well as optometrists as well. But if you do have any of those other provider types in your group, you may want to consider reporting individually as well. Otherwise, you're going to get this cost measure picked up. And this one, just like the other cost measures, are not just based on your costs, they're based on the total cost of care that a patient receives, even outside your practice. So this whole category as a whole is very hard to maintain and control. And starting to dig into your reports and seeing the patients and seeing the charges from what we've done so far with our clients has yielded some issues that need to get resolved that can be fixed internally. But a lot of it is just based on what other clinicians are doing as well. Speaking of that, let's just talk quickly about the rulemaking process. So each year, CMS releases a proposed rule. This comes out in the summer, and our proposed rule for next year was released a few months ago. We have 60 days to comment on that at federalregister.gov. It sounds really formal and difficult, but if you go to that website and you go to the proposed rule, there's a link to leave a comment, and you can either fill out a form or you can just upload like a letter or like a Word document, whatever makes it easy for you. We go through a lot of effort with our VP of Health Policy to make sure that these comments are submitted in a timely manner and then include all of the issues that we identified for our practices. So even if you're not working with us, our commenting efforts may be helping you in future years. We did submit the 2024 proposed rule comments just a couple of weeks ago. That comment period has ended. But if you want to see the comments that we did submit, they're available on our blog on the anatomyit.com website. These comments are reviewed individually by CMS, and they may accept changes. And if they do, those will incorporate into the final rule, which is published by November each year. So at this time, we don't know what the final rule is for next year. But once that's released, they will show if any changes were made. And they also list out all the comments that were made in the final rule to review. Now, like I said, the work that we're doing in the industry should be helping you out just naturally. But if you need additional assistance and you'd like MIPS to be completely taken over by our team of experts, we do offer full service MIPS reporting at Anatomy IT as of today. We have a full service product. You're given an advisor on our team that gets connected into your systems and works with your team to train your staff, make sure that they're working on the specific measures that need to be done. We are keeping up to date on all the latest rules and changes. We are working with your EHR vendor and registry, if you're using one, to handle all of the technical issues and mapping issues to make sure you're getting the most accurate score possible. We're guiding you through those attestation statements and also usually saving you a lot of time. What we find is when we work with a practice, and you might be sitting there thinking this, you just do everything. You do as many measures as possible just because you're not sure what the score is going to be. A lot of these systems don't really tell you what your estimated score is. So you're just hoping, whatever you submit gets you the maximum score possible. When we come in, we look at the procedures and services that you're providing your patients and identify the measures that are best and most efficient to help cut down on a lot of excess documentation. We also can help you save time in certain categories, such as improvement activities and promoting interoperability. We currently have analytics reports that are coming out for cost to help improve that category as well. So with us, it's just a peace of mind. We can submit via whatever method you choose, and we're there to guide you every step of the way. If you're interested in learning more about our MIPS Success program, just to note that we are taking submissions to get started for 2023 up until the end of this month. We do need to start closing out new customers, especially since we're at the end of the year, and also get started on planning for 2024. So if you do need help for 2023, please reach out to us immediately at let's chat at anatomyit.com. Happy to take you through your options. Otherwise, if you're interested in starting for next year, definitely reach out to us and we can help plan out that for next year, as we want to make sure that we're able to implement all the changes that are finalized in November as soon as possible. Even if you're not sure if you want to sign up for our service, we could still help review your current status and make sure you're not missing anything major. Just send over your clinician names and NPIs to our email address, and one of our analysts will take a look at that and set up a call to go over your status. And with that, we will start to take questions. Like I mentioned before, if you have a question, you can use the Q&A feature of this webinar. You can also message in chat if that is easier.
Randy, just pointing out, there was a question that came in that I answered. If you see, it's like indented from somebody, I believe, named Bobby
Sure,
Joe.
yeah, if you could go over that.
So the question was Iris equals Verana Health now. So assuming you're meaning that using Verana Health. So if you have made the switch to Verana Health, are we covered with clinical data registry? So I answered in chat, yes, if you're fully reporting with Verana Health, you have the option to report on QCDR measures because it is a clinical data registry. I think that was our only question that came in so far. Actually, sorry, there's more that are coming in. The rest are a lot of links and blogs that were referenced throughout the meeting that everybody can start saving some documents.
And thank you, Olivia. 10 out of 10 for using MIPS support. Love to hear our happy customers joining the call today. a copy of today's slideshow. We will be publishing this webinar recording on our website as soon as it's done processing. So you should receive an email after we're done with this, most likely by tomorrow, with that information. Thanks, Jen, for providing that detail. That we'll be sending that tomorrow via email. Last call for questions. If you're not sure or something comes to you later, feel free to ask via that email address, let's chat at anatomyit.com. We have a question from Stacy. My office is still on paper charts who have not been contacted by Verana Health yet, although I reached out to them. Renee, can you provide further detail on if that's an option to do manual reporting via Verana?
Yes, so it is an option to report manually within Verana Health. The FigMD is because you're on paper. You may have already known FigMD was supposed to manage manual reporting in 2023, and then that changed probably about 3 months ago. And so FigMD, maybe a little bit longer, FigMD is no longer managing it, and it's fully within Verana Health. It is a fairly lengthy process to be able to report within the registry. If you were to work with us, we're able to simplify the process a bit more, but we are doing some hybrid submissions as a result of the added complexity. So if you're interested, feel free to reach out to us. But definitely, just to answer your basic question, Verana Health does support manual reporting for this year, but it will be very, very different than what you did with FigMD.
Thanks, Renee. And there's a question from Ashley. Will we be doing a 2024 What's Coming webinar? Yes. You can actually see the proposed changes on our blog. We will be doing a webinar once the final changes are out and released at the beginning of next year. All right. Well, with that, if there's any other questions, like I mentioned, you can send that over to let's chat at anatomyit.com. And if you're not working with us yet, definitely take advantage of signing up by the end of the month so we can help you for 2023. Otherwise, thank you all for joining. I hope this was helpful and have a great rest of your afternoon.